Self intro.
Yeah, totally fine.
Everyone, thanks for joining our webinar. My name is Joe Letourneau. I'm one of the reproductive endocrinologists and infertility specialists at the University of Utah's Center for Reproductive Medicine. I, along with Dr. Gross, help patients who are struggling with infertility or have questions about their future fertility. Today, I'm going to talk about female infertility. I, as an OBGYN subspecialist, focus on female infertility primarily and work together with Dr. Gross to focus on infertility of the couple. So from the perspective of a couple, I'd like to just spend about 10 minutes to go over some aspects of female infertility. So at our first visit for a fertility assessment, we typically take a detailed history, and one of the most important aspects of that history is understanding how long couples have tried to conceive and the means through which they have tried to conceive, whether that's with or without fertility treatment. We often learn a lot, and some of the most important things we can learn are from direct history taking or inference from what we learn from history. So couples that have been trying for 3 months likely on average have a different fertility prognosis than couples who've been trying, for example, for 3 years or 13 years and have not yet conceived. From the female perspective, it's very important to understand whether women are ovulating. It's also important to understand whether there are eggs in the ovaries. So ovarian reserve and ovulatory status refer to really the first 2 of 5 kind of main factors for fertility. So using a patient's menstrual cycle, sometimes having an understanding of their progesterone level after they've ovulated are called the mid-luteal serum progesterones. That's usually like a week before the period comes. Measuring that or having an understanding of if body temperature has been rising in the mid-cycle, that's a sign of ovulation, or if ovulation predictor kits have been becoming positive, that's also a sign of ovulation. So ovulation means that eggs are coming out. Ovarian reserve is a way to measure egg counts to see how many eggs are there. There are 2 ways to measure ovarian reserve. One is through the blood through anti-Müllerian hormone, and one is on an ultrasound for antral follicle count. Women who ovulate release at least 1 egg on their own. Ovarian reserve doesn't teach us about whether someone can get pregnant or not, but it does help us to understand how to dose fertility treatments. And in general, women with higher ovarian reserves have a higher chance of conceiving with some of our more advanced fertility treatments. So those would be the first 2 factors to think about. The third factor is on the bottom of the screen here. That's a tubal factor, meaning the fallopian tubes. That's what attaches the ovary to the uterus. And for some women, their fallopian tubes are blocked. And that can be assessed as to whether the tubes are blocked through an X-ray test called the hysterosalpingogram. That can be done through the university. And then rarely it's done through a surgical procedure called chromotubation, pardon me. There's also an ultrasound procedure that can be done to see if the tubes are blocked. That same ultrasound is part of the uterine factor assessment. So the uterus is sort of one of our 4th factors that we think about out of 5 for fertility. And that is to see whether the inside of the uterine cavity or an embryo implants is normal in shape. And that's assessed by a saline and fusion sonohysterogram. We can also look into the uterine cavity with a small camera called a hysteroscope. So that's a surgery that's often done in the office setting to understand that the inside of the uterus is normal. The 5th criteria for fertility that has a lot more detailed information that Dr. Gross could go over would be kind of the male side of fertility and sperm counts and things of that nature. So we kind of think of it from the female side as these 5 factors with sperm counts included. So as we think through the various infertility diagnoses that we can figure out among those 5 factors, we have really 3 main treatments for infertility for women or for couples where a female partner is affected. The first treatment is to make sure that eggs are coming out. So for some women, they do not ovulate. And so we have a procedure called ovulation induction, and that means to try to cause ovulation. Typically, our goal with causing ovulation is not to get a lot of eggs to come out, and often there's a capacity for many women to release more than one egg. We typically only want 1 or 2 eggs to come out, not for some women, the 10 or 15 eggs they might have available in a given month, depending on their own egg count. The way that we do this is with oral medication. Typically, there are 2 main types. One is called Clomid and one is called Letrozole. These are both pills. This can also be done less commonly with shots. The shots cause a little bit more risks for multiple gestation pregnancy, like twins or triplets, and are more expensive than the pills of Letrozole and Clomid. So we try to use the pills when we can. So the first step is to get eggs out if they're not coming out. If eggs are coming out on their own, we often don't need to induce them to come out because that's already happening. We'll go to our second type of treatment, which is called super ovulation. So rather than just getting 1 egg to come out, or maybe 2, now it's actually our goal to get multiple eggs to come out. And on this slide, follicles, what that means is basically kind of like an egg house. It's the support structure inside of the ovary that helps the egg to develop. So when you see mature follicles, or us referring to multiple follicles, that means we're trying to grow basically numerous fertilizable eggs in the ovaries. The medications options are the same as using ovulation induction. We just use a little bit higher doses of Clomid, Letrozole, or injection medication. And this treatment can be used for what we call unexplained infertility. So when we've tried to assess those 5 factors that I mentioned and everything looks normal, or if we're concerned about age-related changes in fertility. So often for women 35 plus, we can become concerned that egg quality and quantity may be going down. And so we want to speed up the time to pregnancy by getting more eggs to come out at once. And so the way that we do this is we often combine this superovulation by getting more eggs to come out with having more sperm meet the eggs by doing something called IUI, or intrauterine insemination. Intrauterine insemination, sorry about that. Intrauterine insemination is typically used really with or without Clomid or Letrozole, but it can be used for mild male factor infertility. So sperm counts where sperm are present, but there aren't as many as we expect on average. Also for, again, that unexplained type of infertility where we've done our testing and we can't kind of detect exactly why pregnancy hasn't occurred. Or sometimes if someone has 1 fallopian tube blocked, this might still be considered. So this could be performed with partner sperm or donor sperm. And as we mentioned in the prior slide, is often combined with other fertility medications. So intrauterine insemination involves collection of ejaculated sperm, processing of those sperm to get the healthy wiggling sperm, and then placing a speculum in the vagina, as you can see pictured here, to see the cervix. This is similar to the way the pap smear is done. And then a small little tube is placed through the cervix and advanced to the top of the uterus, where the sperm are then about 50% closer to the end of the fallopian tube than they would be if they had swum from the vagina. So injecting sperm into the uterus gets them a lot closer. And it also avoids the first part of the uterus, the part that's attached to the vagina, the cervix, has a mucus in it. And that mucus filters out sperm. So we bypass that mucus, we get the sperm much closer, and then in fact, we get more sperms together with the eggs. IVF is sort of our third type of fertility treatment. So again, we have ovulation induction, superovulation, which is sometimes combined with intrauterine insemination, and then we have in vitro fertilization, or IVF. IVF is mainly virtuous in the sense that for some women and their partners, fertilization of eggs in the fallopian tube maybe be occurring inefficiently or not at all. So IVF likely helps with fertilization for some couples. For many women, their tubes are open, but though the tubes are open or patent, the tubes are not functioning well. The tubes have little finger-like projections along their length that are called cilia. And those cilia should move the embryo from the end of the tube that's near the ovary into the uterus, and sometimes they don't function well. So IVF allows us to bypass the fallopian tubes. And lastly, and very importantly, probably the most important thing, is that with IVF, we can get a lot more numbers of eggs and sperm together in just 1 month. So we're limited with superovulation to typically releasing 2 or 3, sometimes 4 eggs into the fallopian tubes. When we do that with superovulation without IVF, we're imagining that many of those eggs that form embryos may not implant in the uterus. And so we're still sort of aiming that one of those would likely take, with numbers like 2, 3, or 4 eggs. However, if a female partner has 10 or 20 or even 30 eggs, we can't really utilize all of those safely by having them go into the fallopian tube, because then we can't control how many land and implant in the uterus. And pregnancies with multiple babies in the uterus have to share the resources like blood and nutrients of the uterus. And so the risk of complications becomes much higher. So our goal is to have one baby at a time. And IVF allows us to do that and just get a whole lot more chances in 1 month. So in a lot of ways, you could think of us accelerating it in the sense where we might get like a whole year's worth of chances all at once if we were able to get, around 12 eggs with IVF. And the number of eggs we get with IVF really varies based on the female partner's age, the medication dose that we use, and their underlying egg count. And egg count is a bit like a shoe size. It's sort of personalized. So even people of a given age can sometimes have different egg counts. So as female fertility providers, we try to give you a sense of what those egg counts might be. There's a special type of fertilization that's really relevant for male fertility considerations. So when we have the egg out, so this purple circle here is the egg, and on the left aspect of the screen as you face it, there is what looks like kind of a larger tunnel. That's actually a suction device that very gently holds onto the egg with a small vacuum to keep it in place. And on the rightward aspect of the screen as you face it is a small needle going in. So that's a glass needle that's drawn extremely thin and is poked into the egg and then drops off a single sperm. So this allows us to fertilize eggs for men who have very few sperm or other issues with their sperm counts. In the absence of having this procedure, which was developed in the 1990s, before that, we could not help men with very, very low sperm counts to achieve a pregnancy. So this was a big scientific breakthrough many years ago, and it's a really important thing that we can do. Dr. Gross may mention it, but if we take sperm out of the testicle directly, which is sometimes done for male fertility concerns, the sperm are not mature enough to swim into an egg on their own to fertilize it without this needle. And so this needle becomes necessary for that as well. Once we fertilize embryos, they develop, as you can see on the leftward aspect of the screen here, for a total of about 5 to 6 days. This is how they would develop in the fallopian tube. So they start as an oocyte or an egg, and then a fertilized oocyte, or basically a one-cell embryo that has the DNA of now the sperm and the egg. And then the embryo undergoes cleavage or cell division. Especially on days 2 and 3, we can still kind of see just a few cells, anywhere from 2 to 10 or 12 cells over those second and third days of embryo development. And then lastly, the stage of pre-implantation or blastocyst is when an embryo reaches 100 to 300 cells, and that's when an embryo would have kind of rolled out of the fallopian tube and wanted to land in the uterus anyhow. So we have embryos developing outside of the body, but in an environment that's a lot like a fallopian tube. So they are, for example, in the dark because there are no lights in the fallopian tube. They have the nutrient content of fallopian tube fluid that they're floating in. So there are sugars and proteins and things that they need, certain oxygen concentrations that they need to grow. And they're kept at human core body temperature, which is 37 centigrade. So that's kind of the temperature on the insides of our abdomen and pelvis. And that's where embryos like to grow. And that's where their cells do well with their biological cell division. So once we reach 5 to 6 days, we're ready for an embryo transfer or to place the embryo into the uterus. Prior to that, we can sometimes do what's called pre-implantation genetic testing. This is a test to help us pick. If we have a group of embryos, say 2 or 3 of them or more, it helps us to understand which single embryo should we try first. So if there are numerous embryos, we freeze the remaining embryos and we put that single best embryo in first. This test can help us to find, for women of some backgrounds and ages, it can help us to hone in on which might be the best embryo. Should be noted clearly, this is not a test for a perfect baby. It's not a test to optimize baby health. It may, in some women whose age is over 40, possibly help to reduce the risk of things like Down syndrome, but it does not perfectly prevent things like Down syndrome. There are the main goals of this test is to look for chromosome numbers. So that's akin to if you had an instruction book for a person, their genome, that would be like the book chapters. So we can see the chapter level. We can't read every sentence. So the sentences would be like genes. There are 25,000 genes in our genome. So neither we nor anyone has the technology to read the entire book. And so we don't have a technology for testing for a perfect baby, but we can sometimes, if there's a pre-identified condition of concern that's a single gene, we can use this technique to also look to see if an embryo is affected by a particular sort of family history, single gene that's been identified already. It's important to understand that infertility increases with female age. There is an impact of male age too, but it's more subtle than female age. So with female age, the percent of women who are infertile by age group, the percent of women that will remain childless, and this is, I would say, not as accurate today. This is from almost 40 years ago. But basically, women who've not yet conceived by the age of 40 to 44, there's a high likelihood of remaining childless at that point. This is in the absence of having as much IVF and fertility treatment as we do now, but it does illustrate that as fertility or as age advances, fertility does drop for women. And so it's important for women under the age of 30 to come see us, probably under the age of 35 to see us after trying to conceive for 12 months and not yet becoming pregnant. For women between the ages of 35 and 40, it's important to come and see us after 6 months of trying and not becoming pregnant. And then for women at the age of 40 plus, perfectly appropriate to come see us even at the start of planning to get pregnant or after just a few months. We just don't want a lot of time to elapse before we can help to intervene, because the sooner we can help, often the more effective our female fertility treatments can be. So this graph shows that age not only affects female fertility, but as I mentioned, the sooner we can intervene with fertility treatment, the better. When you can see on this graph is kind of between the ages of the early 20s and 38, really, fertility treatments are quite effective and then begin to drop off in their effectiveness, where actually between intercourse and fertility treatment, we don't really necessarily get a lot of benefit with one's own eggs after the age of, say, 43 or so, typically. However, as you can see at the top, donated eggs for couples for whom that's an idea that they are open to. It's a great way to build a family. That's always an option. And donated egg pregnancies can occur even in the later 40s if need be. The donor egg success is not written here, but typically with an egg donor in their early 20s, we'd expect the success rate really across all ages to be 50 or 60% chance of a live birth. And that's really because what we're really seeing here with people's own eggs, that's what this graph illustrates, that as age increases, one's own eggs quality goes down. And so we can overcome that by using donated eggs. So the uterus generally performs really well in terms of a pregnancy, even at later ages. I'm going to wrap up our discussion there and turn it over to Dr. Gross. Thanks for your time and attention.
Thank you. Sorry, I was on mute. Let me get my screen up, and thank you, Dr. Letourneau. That was great. So I'll get my screen shared here in a little bit. Okay, I am Kelli Gross. I'm an assistant professor in urology, and I specialize in male infertility and men's health. So I'm going to cover the male infertility side of things, kind of just the converse of the female side, and I'll expand upon some of the things that were already discussed here. So one thing that is often ignored is that men can be infertile too. When a couple's infertile, the first question that's often asked is, what's wrong with her? There's a lot of the information that is directed at the females, the blame, etc., but it's fairly frequent that there's a male factor issue as well. So what do we define infertility as? It's defined as a failure to conceive despite 1 year of regular unprotected intercourse. Like Dr. Letourneau was saying, it doesn't mean that every couple that comes in has to wait a year. That's just what our definition is. 15% of couples will experience infertility, and 40 to 50% of couples with infertility will have an identifiable male factor. And 10% of infertile men will have no sperm at all, which we call azoospermia. It's also not completely uncommon for infertile men to have a serious medical issue that is underlying. So we think it's very important to make sure to get a proper workup for these things. There's also more common pathology that aren't serious medical pathologies that we'll see in men who come in with infertility. So that'll cover later in the presentation. So what is the underlying anatomy in male reproduction? So the testicle is where the sperm is produced. The epididymis sits on top of the testicle. It's right here. It stores and matures the sperm. The vas deferens is what is used to transport the sperm to the urethra via the ejaculatory ducts. And the seminal vesicles is what stores and produces most of the fluid that makes up the semen. So it's this purple structure back here as well, but this is a, sorry, hiccups, closer view of it. So these are seminal vesicles. This is the prostate right here. The prostate adds additional fluid to the ejaculate. There can be a lot of things that can affect fertility as far as the ejaculation process. Some of these don't necessarily affect fertility, but can affect sexual function. So premature ejaculation, that's ejaculating too early, delayed ejaculation, having difficulty ejaculating, retrograde ejaculation, that's when if you ejaculate, it goes backwards into the bladder, or ejaculating, not ejaculating at all. Those can all be problems that can potentially affect fertility. So the testis itself, it takes about 3 months to make and ejaculate sperm. That happens in the seminiferous tubules here. And then you can see here, this goes to the epididymis, which is a head, and then a tail, makes its way to the vas deferens here. This is just a little bit more of a close-up view of the what we call more gross anatomy. So this shows kind of the blood supply and the orientation of those things in the outer layers of the testicle. Hormones are very important in this whole pathway. So in the brain, stimulating hormones, this GnRH is made that stimulates the pituitary, which makes even more stimulating hormones, the FSH and LH. And these two hormones act on the testicles. So the FSH has more of an effect on the sperm, and the LH has more of an effect on testosterone. The testosterone itself will feed back onto the pituitary and hypothalamus and tell it to shut off if this level is really high. So that's why we have to be careful in when patients are given testosterone, that could have some very serious negative effects on fertility. So men are typically making sperm very frequently. Average sperm production is about 100 million sperm per day, which is more than 1,000 per second, which is pretty crazy. And the typical ejaculate will have about 100 to 300 million sperm, and it's usually about 2 to 6 milliliters. These are the terms that we use when we're talking about semen analysis. There's a lot of big words here. So the commonly heard one, so aspermia means no ejaculate. Asthenospermia means that the sperm is not moving with a normal level, so low motility. Azoospermia means no sperm at all. It has to be a specially processed specimen to look at that for us to call it azoospermia. Normospermia, it's a normal sperm amount. Oligospermia, low sperm counts. Teratospermia, that means that they don't necessarily look normal, although it is quite typical for sperm to not look totally normal. What we call normal is 4% completely normal looking sperm. It's based on these certain criteria. So anything less than that, we call it teratospermia. Cryptozoospermia is having less than 1 million sperm. So sometimes what that means is whenever you spin it down, then you see sperm. Lots of big words there. And I will, if I go back over those, we'll remind you what they mean. So concentration. So I'd say this maybe has changed to some degree, not necessarily in concentration, but the total motile count. So the three biggest factors that matter are the count or concentration. So the more sperm that you have, that is a helpful thing. Motility, that's one of the most predictive things. And when you multiply that concentration or the total number of sperm with the motility, you get the total motile count of the sperm. And that's really the best measure of fertility. We've known for a long time that at least 25 million total number of moving sperm has big effects to help with fertility. So we try to get people as high as possible, and 25 million has for a long time been a goal level, but we've also found more recently that you still get additional benefits above 25 million. So increasing to 50 or 100 million is helpful, but a goal number for us would be 25 million is a good number to shoot for. That you definitely get big effects up to that point. The morphology, or the way that the sperm looks, is the least predictive of fertility. So assisted reproduction, this is all things Dr. Letourneau went over. So what I'm going to cover as very basic as far as how it relates to male fertility is intrauterine insemination and in vitro fertilization. So intrauterine insemination is where you put the sperm directly into the uterus. It gives a shorter place to travel. We also do some processing, which has also been shown to help with outcomes. And then in vitro fertilization is where you give medications to make the eggs grow, take them out of the body, and then put them with the sperm outside of the body, and then transfer them back into the uterus. So what we try to do with male fertility is, if we can, try to shift things so that instead of having to do in vitro fertilization, or, in males who have no sperm at all, giving them the ability to do in vitro fertilization, and taking them to potentially something that's a little bit more affordable. So we try to optimize things. Likewise, even if we can't take somebody who had to do in vitro fertilization and can now do intrauterine insemination, the things that we can do can also help outcomes. So if you're going to be doing in vitro fertilization anyway, whatever we can do to improve outcomes will be helpful in the long run, make the whole process easier. So we try to optimize. So what do we know about male fertility? These are just kind of some basic things. So exogenous testosterone, meaning testosterone that is like a gel or cream or injection, something that's not given for, so we use other things to boost the testosterone like clomiphene or HCG, but specifically giving testosterone will make men infertile the vast majority of the time. And in some men that can be permanent. It leads to the testicles to shut down. They stop making sperm. They stop making testosterone. So that's something that you have to be careful of, because not everybody knows that. Not all healthcare providers know that. We also think that leading a healthy lifestyle can help with sperm count. So the things that you're supposed to do, losing weight if you're overweight, eating healthy, exercising, all those can potentially help with fertility. Avoid exposure to wet heat. That means like hot tubs, saunas, those kinds of things. And a lot of times the cause of male infertility is genetic. So this is kind of a breakdown of what we will often find after a male fertility evaluation. So varicoceles are very, very common. Depending on where you look, it'll be, 38 to even up to 50% of men have a varicocele who are being seen for infertility. A lot of times we just don't know why. There can be blockage issues. There can be issues with the testicle itself, issues with ejaculation, and issues with intercourse. These are all potential things that will have a factor. So our goals in a male fertility and evaluation are to identify and treat any reversible causes, identify any irreversible causes, and use what we need to do. So do something like in vitro fertilization if possible with patient's own sperm. We want to identify when we will not be able to find sperm. We want to find other medical diseases that are associated with infertility that may need treatment. Genetic causes should also be identified that can be transmitted to offspring. So what are the basic things that we do when evaluating men with infertility? So number one, a history. So just getting information about exposures, any medical histories, et cetera, are where we start. See how long the couple's been trying for, if they've had prior children, things like that. Physical exam, so looking for varicocele or dilated veins, which I haven't gone over in excess yet, or too much yet, but we will go over in a little bit as to what that means. We're also looking for the vas deferens to make sure that there is a pathway for the sperm to get out that can be missing. We're looking for masses of the testicle and so forth. Labs will typically do hormones because that can be a factor even when people don't realize it. Some men are asymptomatic and we just find that the testosterone's low. The semen analysis gives us a lot of information. And then there's also adjunctive tests that we'll use sometimes. So genetic testing, imaging tests like ultrasound, we'll use in certain situations. So what genetic testing are we talking about? So one thing we do very frequently is looking for Y chromosome microdeletions. So this is part of the genetic material that codes for essentially the male factor. So what makes a man, and a lot of that is sperm. So this is not completely uncommon. We see it sometimes in men who have very low levels of sperm, and it's in up to 13 to 15% of men with no sperm at all in the ejaculate. And there's no associated issues except for infertility. There's 3 different types of this mutation, and 2 of them we don't recommend looking for sperm because it's very unlikely to be found. But there is one deletion where we will find sperm at a reasonably high rate. So looking for sperm can be helpful. As far as other genetic evaluations, the karyotype, this is looking at the chromosomes. One thing that this is designed to look at is looking for Klinefelters, which we'll see in men with very low sperm counts or no sperm at all. So it can happen in up to 15% of men as well. And overall, if we just looked at all men, about 1 in 600 men will have Klinefelter's disease, and a lot of these men won't know. We're also looking for other switches in the chromosomes. So you can have what are called translocations, where small parts of the genes are getting switched between 2 different chromosomes, and that can affect fertility to some degree as well. So male infertility treatments, we start by looking at diet and exercise, lifestyle, smoking, hot tubs, baths, look at things that are potentially affecting things. So hot tubs, baths, saunas, those can be very commonly issues that can affect the sperm count quite a bit. And those effects can last usually about 3 months or so. So using those kinds of basic changes, you can have a big difference in sperm count. So we'll go through those things and, do what's necessary based on each individual person's lifestyle. We can consider hormonal treatments. So if the testosterone's low or the low end of normal, clomiphene citrate, which is the same thing that Dr. Letourneau was talking about for women. It's what's called a selective estrogen receptor modulator. What that does is it acts on the brain, essentially making it think that the hormone levels are low, and this increases the stimulating hormones and thus the testosterone. HCG is also an option. That's an injection that we use that acts like the stimulating hormones, and that raises the testosterone level. So that can potentially help with sperm production. It's usually not a big difference in most men unless the testosterone is very low, but we'll still use it very frequently because it is quite common to see low testosterone. So the varicocele, so I've talked about this in passing a couple times. This is one of the most common things that we see in men who are being seen for infertility. So what that is abnormally dilated veins that drain the testicle, and those can impact male fertility. So what we think that happens there is it potentially just traps heat in the testicle, and the sperm doesn't like heat. It's why hot tubs and baths and things like that are so bad. So this is one more thing that can just trap heat in the testicle as far as we know. And it can affect sperm concentration, it can affect motility, it can affect morphology. We can see some pretty big changes in the semen analysis after fixing these. However, overall, they're not harmful for most men. They can affect the testosterone to a small degree. It can affect the size of the testicle, but really the main factor is fertility. It's also progressive, treatable, and reversible, meaning that you can see worsening of the semen analysis over time if untreated. It is treatable, and that there's surgery that we do to repair that. And it's reversible. So when we treat it, we'll typically see an improvement in the semen analysis. I say one situation we don't necessarily know is we'll see in men, boys. So during puberty, we always track the size of the testicle, so that if they've got a big varicocele, we try to, if we notice a big change in the size of the testicle, we try to treat it earlier. But in adults, where we don't tend to see quite as much as far as the changes actively happening in the size of the testicle. But that's, I'd say one thing that maybe that's a little bit less reversible after you see some size changes, but that's again not typically in adults. But again, this is something that is really pretty common. So we see up to about 50% of infertile males having issues with this. But if you just looked at everybody, it happens at about 15 to 20% of men. So a varicocelectomy is a surgical procedure that we do to divide these dilated veins. We essentially make a small incision in the groin, probably less than an inch, and then bring up all those veins and then just divide the veins. We use an operating microscope. So it just gives us about 40 times the magnification, and that gives us a great view of the blood supply of the testicle. So the way that this approach is called is the one that we do is a microscopic subinguinal varicocelectomy, which is a very big word, but it essentially means, or words, it essentially means that we're going above the scrotum, kind of in the low groin. We're using an operating microscope and then using that to divide all of the veins. This is the gold standard for doing a varicocele repair because it has the lowest complication rate, even compared to different techniques that don't make incisions. So there's different techniques that go in through the blood vessels to get rid of varicoceles, but those actually have higher complication rates because they use coils to cut off the blood supply. Those can migrate and go to the lungs and things like that. And it also, the microscopic subinguinal varicocelectomy also has the lowest retreatment rate. So that's what we do. It has been shown to improve potentially the semen analysis and or sperm quality. It's been shown to improve the pregnancy rate. So one of the better studies that we've got, they had a group of men or two groups of men who had varicoceles, and they randomly assigned them to have them fixed versus not. And in those who did not have them fixed, they had a 17% pregnancy rate. And in those who did, they had a 42% pregnancy rate just from fixing the varicocele. So it's really one of the things that has the biggest effect in male infertility. So we'll often recommend them be treated. There's also some data that may help reduce birth defect rates or recurrent miscarriages in certain cases. So that's something to be offered in those situations. You can see that it does take a little time to see an improvement in the pregnancy rates. And then typically about 6 to 8 months, you'll see the max as far as pregnancy rates. And then when people are having a hard time still conceiving over a year, we start thinking, hey, maybe that wasn't the varicocele that was the problem. We may be thinking that sooner, but most people will see a big effect by about 6 to 8 months. So azoospermia, that's no sperm in the ejaculate. It falls into two basic categories. So one is a blockage issue or obstructive. And then the second one is non-obstructive, so a sperm production issue. When we're talking about obstructive, there's two basic ways that we can manage it. So one is reconstruction. So where is the blockage? And then fixing it. So if it's in the vas deferens, the tube that carries the sperm, then we can find that blockage, bypass it, and just connect the two parts to the side. So we do that in vasectomy reversals. With a sperm, or sorry, with a blockage in other places. So we were talking about the ejaculatory ducts kind of near the prostate. That's another place that things can be blocked. So sometimes we can open it up there. So that just kind of holds true for anywhere that we see blockage, trying to find that and bypass it. There's various ways that we can figure out where the blockage is, either by ultrasounds. That's going to be typically the first start. etc. But it kind of depends on the diagnosis of having an obstruction issue. Another option of what we can do is just do a sperm extraction. So getting sperm directly from the testicle, but that needs to be done with in vitro fertilization because the sperm isn't mature. Non-obstructive azoospermia, so that's a sperm production issue. Typically in that situation, we're talking about a microdissection testicular sperm extraction or MICROTESE. That's looking through basically the entire testicle for pockets of where sperm is being produced, getting sperm from there, and then freezing that to be used for in vitro fertilization. Again, getting sperm directly from the testicle, it's not mature, it needs to be paired with in vitro fertilization. But this can be used in, again, men who don't have any ejaculated sperm. There are other options to start a family, adoption, donor sperm, embryo adoption, those kinds of things. So if these things sound daunting and something that you're not interested in, there are other options. But in those who are interested in pursuing what they can to have biological children, these are options that we will pursue sometimes. The vasectomy reversal or vasal reconstruction, that's reconnecting the male reproductive tract after vasectomy. That falls into one of two categories, typically a vasovasostomy, which we'll call a VV. So this is reconnecting the vas back to itself. So that's what's divided during a vasectomy. All we do is just connect, go around this blockage here, and then connect a little farther back, each end back together. So it's easier for us. It tends to have higher success rates. We'll say, 95%, something like that, if we get to connect the vas back to the vas. Sometimes the blockage, however, isn't where the vasectomy was originally done. Sometimes it's over here near in the epididymis. When that happens, we have to connect the vas to the epididymis. It's called a vasoepidydymoscopy. Sometimes you'll hear that also referred to as an epididymovasostomy. Those are the same procedure, so either VE or EV. So that's more involved. It does typically have a lower success rate, maybe about 70%, but still not bad. Most men will need a vasovasostomy, although the farther that a man's out from a vasectomy, the more likely they are to need a vasoepidydymoscopy. So vasectomy reversal, again, is really pretty good for hooking the vas up to the vas. Not bad hooking the vas up to the epididymis, but not as great. And getting sperm back to the ejaculate's pretty fast for a vasovasostomy, but not quite as fast for a vasoepididymostomy. And here you can see this is when we do a vasovasostomy. We just put some stitches to connect the two ends. They're really tiny, smaller than a human hair. And then the vasoepididymostomy we don't have a picture of, but essentially we're hooking one of these tubes into a much, much tinier tube, which this is already very, very small, but it's kind of funny how big these sutures look compared to what you do when you're doing a vasoepididymostomy. So what's the difference between we're talking about sperm extraction. So there's two different kinds of sperm extractions. So a TESE or TESE versus a MICROTESE. So a TESE is what we will refer to So a testicular sperm extraction, that's the abbreviation we use for testicular sperm extraction. TESE is testicular sperm aspiration. So what a testicular sperm extraction is getting just a small amount of sperm directly from the testicle. It's not opening the whole testicle. It's typically making a small incision in the testicle and in the skin and just getting kind of a little bit of the tissue below it. We will often do a TESE or testicular sperm aspiration because it doesn't require any incision. So it tends to be faster and also have quicker recovery. And I find we get the same amount of tissue as you would from a TESE, just with the way that we do it. And it lets you kind of sample randomly from the testicle, which I like if there's a sperm production issue. However, it's not designed for sperm production issues. It's more designed for blockage issues, but sometimes it'll give us information when diagnostically we're not exactly sure if it's a blockage or a production issue. So sometimes we'll do that in that situation. So those are both designed to get sperm from the testicle. We don't find sperm 100% of the time, but that is certainly what it's designed for. On MICROTESE, however, we open the entire testicle and really look through the whole testicle. So this is the testicle without the surrounding connective tissue. This is it opened, and this is trying to show you the contents of the testicle. Doesn't look exactly like that, but not too far off. And this is showing you what the tubules look like where the sperm is being produced. Excuse me. If you see a dilated one, then that's a sign that, hey, this is a pocket of where sperm is potentially being produced. So we look for dilated areas of these tubules. It's micro in that we use a microscope. It's not micro in that it's like really, really small. It's obviously more invasive than this testicular sperm aspiration. So the sperm aspiration takes like the actual time for the procedure itself is like 5 minutes or something like that. And then we look for sperm. This one we're spending 2 hours, something like that, really looking through the entire testicle. We have somebody from the lab with us looking as well and letting us know, hey, these are areas you need to look more. We found some sperm here. So it's definitely more involved. So in summary, infertility is a couple problem. Both partners should have a simultaneous and thorough evaluation. Many causes of male infertility are treatable, and some treatments are pretty simple. Treatment can help in shifting the level of technology required to achieve pregnancy, like from having to need in vitro fertilization to instead being able to get pregnant with IUI. And there is some hope for even the most difficult cases of male infertility. Right. Well, thank you so much. It's my presentation for today. Yeah, if you ever have any questions, I'm always happy for anyone to reach out, and I'll answer what I can. I think we don't have the Q&A today, but again, I'm always happy to answer anything to think of. Great, thank you.